So I have the pleasure of introducing Dr. Kira Ryskina, who's visiting us from the University of Pennsylvania. She's the first IHPI emerging scholar who's visiting us this year. So Kira started with her undergrad studies at Yale and then has basically been working her way down the East Coast since then. So medical school and residency in New York, and then to Philadelphia and Penn for general internal medicine fellowship, where she's now an assistant professor of medicine and a senior fellow at the Leonard Davis Institute. So from her personal statement when she applied for the program, she said she's interested in understanding how physician practice patterns and organization relates to the cost and quality of care for aging adults with multiple chronic conditions. And to do this work, she links a variety of survey, administrative billing, and other secondary data sets to answer these questions, which is like sort of a topic that's like catnip for this audience. So I know we're all looking forward to your talk. And we're really glad that IHPI could provide the reason for your first field trip to Michigan. So thanks, Kira.
Thank you so much for having me. I had an amazing day meeting many of you, and I really appreciate all the hospitality and advice. So I will talk about the role of physicians and advanced practitioners in post-acute care outcomes of patients discharged to skilled nursing facilities. These are my disclosures. Most of the work here was supported by the National Institute on Aging. Here are my objectives that I proposed, and as I was putting together the slides, I realized these are really ambitious. But I will try to touch on most of them, and I would love to have a discussion at the end to be able to talk about, implications, your thoughts, and potential next steps. So I'd like to start with this slide. A lot of people are kind of, I've seen this before. For some reason, it's really stuck to me. It's just basically a U.S. Census data showing that in 15 years, we're going to have as many adults over the age of 65 as children under the age of 18. So a lot of people I talk to about what I do, I have a hard time explaining it. It has to do with, skilled nursing facilities, but they're really nursing homes, and then what are nursing homes, and why do we care? And I see this glazing over sometimes when I talk about nursing facilities. But there was a recent, I think this sort of drives home the point, but also there's a recent NBR study that estimated that of the adults aged 51 to 65 today, over half are going to spend some time in a nursing home. So basically all of us are going to spend some time in a nursing home if things are go the way they're going now. So I'm going to go over some of the language because, again, it's very wordy and confusing, and I apologize because I keep going back and forth between some of the terms. So what are skilled nursing facilities versus nursing homes? I'm currently a hospitalist, or somebody who works in the hospital, and I discharge a lot of my patients to skilled nursing facilities. Skilled nursing facilities typically are places that are co-located in a nursing home. There are patients often in the same room or on the same floor. Sometimes they're separated. Skilled nursing facilities have to be certified by Medicare and Medicaid, so they have to meet certain requirements, but there's really a lot of overlap in terms of their physical place, the staffing, as well as regulations. One thing that's different is that skilled nursing facilities are typically reimbursed by Medicare, and Medicare pays for 21 days of short-term rehab or skilled nursing needs, and then they subsidize up to 100 days per episode. And after that, Medicare, some of the patients transition into long-term care or require more care, but Medicare doesn't pay for long-term care. So those patients are then either on Medicaid or self-pay or private pay, and they end up being nursing home patients if they require custodial care. For example, there are often patients with dementia or some sort of long-term disability that requires long-term facility custodial care. Why else do we care other than the fact that we're all going to be in a nursing home someday? So a lot of the public awareness of post-acute care has been around the fact that it's very costly. Just to kind of drive home the point, these are some estimates from 2016. The payers are different. So the big house is acute hospital care, public payer spending. So Medicare spent about $140 billion, Medicaid about $50 billion. For SNFs, the skilled nursing post-acute care piece, Medicare paid about $30 billion. And for nursing home, Medicaid paid about $50 billion. I should also mention that evidence shows that about 75% of the variation in spending for Medicare has been attributed to variation in use of skilled nursing facilities. So there's a lot of variation in the use of this benefit, and it drives a lot of the variation in costs for Medicare. And then finally, nursing facility stays are very common. This is again for an elderly population that's Medicare insured except for the nursing home piece. So there were about 10 million hospital stays in 2016 that Medicare paid for. About 2.5 million of them were ended up in a SNF. And then for the nursing home, these are long-term stays. So this is 1.3 million residents in a nursing home. And the trends in sending people to a skilled nursing facility after a hospitalization are not really changing. There was a little bit of a uptrend in the early 2000s. This is a recent paper by my mentor, Rachel Werner, that looked at institutional post-acute care and included both inpatient rehab and skilled nursing facility care. I will say that inpatient rehab has very strict criteria that has to be met to get into inpatient rehab, whereas skilled nursing facilities are much looser. So there's a lot more variation. And I don't have a pretty graph just looking at skilled nursing facility, but it looks about the same. Most of this facility-based institutional care is actually in SNFs. And lastly, what do we know? So let's say we're paying a lot of money. A lot of people are using this service, but it's great. People are getting rehab, they're getting stronger, they need the service. So unfortunately, as you probably heard, and many of you have published on this, quality of care or outcomes of skilled nursing facility care for short stay subacute rehab are not great. This slide actually shows a public reporting program that the government has, Medicare has, called Nursing Home Compare. They have this 5-star rating that looks at staffing, health inspections, and some clinical quality indicators. This program was instituted in response to concerns about poor quality in the skilled nursing facilities and poor outcomes. What it shows is that between 2009 and 2013, the proportion of facilities that had the 5 or 4-star ratings increased a lot. And unfortunately, what we found and others before, other researchers also substantiated this, is that the quality that is measured by the 5-star rating, which shows improvement, doesn't really correspond to the things that we care about, like readmissions, mortality. So this slide shows on the y-axis potentially preventable hospitalizations. It's a little bit of a strange measure or unusual measure where we looked for the number of potentially preventable hospitalizations per 100 patients within each 30-day interval that the patient spent in a nursing home. And what you can see here is that before 5-star release, there was really a very minimal correlation between the 5-star rating and the number of potentially preventable hospitalization. But actually, if anything, it was going in the right direction. Whereas after 5-star release, the line is flat. So your risk of being readmitted from a 1-star nursing home is similar to a 5-star facility. So I'm just going to leave that, and like I mentioned before, there's a lot of data talking about outcomes of these facilities, and you're just going to have to trust me for a little while that outcomes of skilled nursing facility care are generally poor and variable. And I'll kind of circle back toward the end and show you some more numbers. I should also acknowledge other efforts that are out there that are being tested and implemented to improve nursing home care quality or skilled nursing facility post-acute care quality. There are obviously regulatory and legal efforts, certifications. I mentioned a couple of the public reporting initiatives. And then there are sort of specific multifactorial interventions that have been implemented, like Interact, telemedicine type connected care models, and of course like grassroots quality improvement efforts. A lot of healthcare organizations have also started looking at post-acute care as part of like ACO, value-based payment models, trying to improve efficiency of that component of the hospital stay. So I'm not going to talk about any of those interventions, and frankly, nothing seems to be like the magic pill, just like is common in healthcare. What I was interested once I started looking at this space was what actually happens when patients are leaving the hospital and going to a skilled nursing facility from the perspective of a physician. Working in the hospital and in my training, and also in my work in the clinic previously, I very rarely interacted with a physician who was taking care of my patients in a skilled nursing facility. Once I started studying this field, I started to work with medical directors and other clinicians who worked in the field. And the things they were telling me kind of did not correlate very well with what I was telling patients to expect when I was discharging them to get a little rehab. So what we did, this paper actually just came out in Health Affairs, but it's based on a cohort of Medicare beneficiaries discharged between 2012 and 2014 from an acute hospital stay, and who went to a skilled nursing facility for post-acute care, and all of their physician billing data to Medicare. So what you can see here is that on the x-axis, it's the number of days since SNF admission to the first visit by a physician that we saw a claim for. And the y-axis is the proportion of stays. So to summarize, about 10% of discharges, we actually didn't see any physician visits. They had other Part B billing, but not for a physician visit during their SNF stay. And while about half of the visits occurred in the first 48 hours after admission to a SNF, there were other visits that occurred on day 3 or 4, etc. So we were on one hand surprised to see that was a little longer. We knew that a lot of these patients weren't going to be seen the next day or even in 2 days. but, you know, this sort of potentially made sense to us if sicker patients are being triaged and being seen first. And, you know, I'm a physician, so I understand that I can't see every single patient at the same time fairly, you know. So we wanted to estimate the risk, we basically modeled the probability of being seen during their SNF stay, and also modeled the time to their first visit based on all the patient characteristics that we could assess, things like how many times they went to the hospital in the prior year, how long their hospital length of stay was, Alex-Hauser comorbidity index. So we kind of tried to capture if physicians are triaging sicker patients to be seen sooner, can we see that in the data clinically? And then at the same time, we included variables that were nursing home characteristics. So we, so if physicians were seeing sicker patients sooner, we expected to see those differences in the effects from our models. And I unfortunately don't have the space to show you the patient characteristics, but the reason I'm not showing those to you is because they're in the paper, but there's not a lot of variation across clinical characteristics. It's not like people with higher Alex-Hauser index were being seen sooner. You know, there were no demographic differences that we could see. So there was nothing really striking there. What was striking to me were the differences based on location of the nursing home, so rural. Ooh. Rural.
You just needed a regression.
Did I do something? So rural nursing homes you were less likely to be seen, period, and your time to first visit, the number of days, you had a higher IRR for that. There was also geographic differences and differences based on the size of the facility. So patients who were in a smaller facility were less likely to be seen, and also had more days to their first visit, kind of adjusting for all the other things that we put in the model. And then when we tried to publish this, a really valid question that we were interested in, we looked at before, but we thought we weren't looking at it in the most rigorous way, was, so what are the outcomes? This is all great, but we don't really care about physician visits. We care about rehospitalizations and mortality. And the reason we were hesitant to submit this was because it's obviously there's endogeneity between being seen by a physician and like going back to the hospital. So clearly some patients might rightfully be sent to the hospital before being seen because they have a new issue or they need to be, tested for or something like that. So we didn't attempt to tease that out in this analysis. But I think the findings are still a little striking, and I wanted to show these to you. So we looked at rehospitalizations within 30 and 7 days and deaths within 30 and 7 days. And this also speaks to the high risk of poor outcomes of going to SNF overall. And then this measure of successful discharge from SNF to community is really the ideal outcome. The reason we tell people they should go to subacute rehab is so that they can get stronger and go home. The orange bar is for patients who didn't have any visits, and the blue bars are for patients who had at least one physician visit. As you can see, there's a dramatic difference. We, to kind of try to address this issue of patients being like reverse causality, we looked at the length of stay for patients who didn't have any visits, and we found that most of them stayed for at least a week. So this wasn't like a early discharge to the SNF that got sent back the next day. They seemed to have enough time to see a physician. But again, this is completely unadjusted outcomes. So that brought up the next question of who are these physicians, and are there maybe physicians who are more focused on nursing home care or skilled nursing facility care. So we were lucky to have access to a public use file that's downloadable from the internet called, actually public use file, but it was provider utilization data at the line item level. It's aggregated by the NPI, the IHPI code, and the place of service. And it's now available through 2016. I think when we looked at this, it was only through 2015. It's, again, a publicly available file, so any IHPI level observations with 10 or fewer individuals are excluded, so there's a limitation with that. So small volume services are missed for these physicians. However, these are all visits. So there are specific visit codes for nursing home care, and you can actually separate skilled nursing wing and hospital, nursing home wing based on the place of service. So we felt that, physicians who are seeing, making fewer than 10 visits could be ignored in this study. We didn't know where to start defining a nursing home specialist. There's no specialty. There is a AMDA, or a long-term Post-acute and long-term care society that has about 5,000 members, but they provide some training, but they clearly don't cover everyone who takes care of patients in the nursing home. So we wanted to use this billing approach to define a nursing home specialist, and we adopted what hospitalists did, which is setting the threshold of at least 90% of line items for that year for nursing home services. This is something that Medicare is now using to define a hospitalist in their claims. So we just went with that, and I'll tell you a little bit more later about whether that made sense or not. We limited this to generalist physicians, internal medicine, family medicine, geriatrics, and general practice, and advanced practice providers, physician assistants, and nurse practitioners. We also used some data from the long-term care focus database to get the number of occupied beds in each nursing home. So to normalize this across different facilities, because facilities were opening and closing, and the number of occupied beds also varied over this time period, we created this measure of the number of nursing home physician specialists and advanced practice providers per 1,000 occupied Medicare certified beds. And this is what we saw, which was surprising to me, but also intriguing. So between 2012 and 2015, the number of prescribing clinicians who specialize in nursing home practice increased by 34%. there's a total of about 30,000 clinicians who were who submitted any billing for nursing home care during that time, and about 7,000 of them were exclusively, basically more than 90% of the billing was from the nursing home. The blue bars show overall rates of specialists per occupied beds. The orange bars are the physicians, and the green bars are the advanced practitioners. So you can see most of the increases among advanced practitioners. Most of those are nurse practitioners. We also we tried to see whether this is kind of different areas catching up to respond to the increased use of post-acute care. The changes are definitely somewhat corresponding to like rise in post-acute care use in the Northwest, I think, but it's kind of all over the place. And one thing that you can see is that the red, all the red spots are an increase in SNFists. So there is definitely more red than blue. It didn't result in a homogeneous level of SNFism. I had to say that. And then we also looked specifically at post-acute care specialists. So these are people who plurality of their claims are for the post-acute care services provided in a nursing home versus long-term care. So the implications of this were, we were kind of excited that there's clearly a trend here. As somebody who works in the hospital and interacts with hospitalists a lot, the hospitalist trajectory came to mind. This is obviously, if anything, it's at the very beginning of that, but it's certainly interesting to study. Prescribing clinicians who treat nursing home patients increasingly specialize in this practice, it seems, at least relative to other services provided to Medicare fee-for-service beneficiaries. But whether this is a response to increased pressures to improve quality, whether it's driven by physicians or the nursing homes was not something we knew about. And also, so basically our next step was to ask, is there any correlation with outcomes or any kind of quality measures? So we did this ecologic analysis, also using publicly available data to measure the association between regional nursing home performance on clinical measures and the prevalence of nursing home specialists. We used Nursing Home Compare database and selected 6 quality measures that we deemed to be relevant to or be under control of a prescribing clinician, like a physician or a nurse practitioner. Everything was aggregated at the HRR, the hospital referral region level, and again weighted by nursing home beds. And then we use the same provider public use file to measure, to identify nursing home specialists. The models were adjusted for commonly used nursing home characteristics, and we had some data about the level of acuity or case mix for each nursing home, also using LCC focus data. So this was, again, very much just a correlation, but it was interesting that it was going in the right direction. It was significant. We looked at antipsychotic medications for short and long stay. Those are 2 separate measures: restraints, catheter use, and depression, and urinary tract infection. Depression obviously actually is going not a good direction, but we hypothesized that maybe, or we explained this as perhaps, diagnosing more depression or identifying and treating depression, which is what would flag you for that measure, is a good thing. And then the journal asked us to split it up into physicians and nurse practitioners. And there, the antipsychotic medication use, was less, and the urinary tract infection, the urinary catheter use was also less, whereas it looks like the depression measure association was stronger for the nurse practitioners, but not the other measures. So this was sort of encouraging. Obviously, it was a very simplistic correlation in trends geographically. We again try to think about depression, what it meant, and we're not too bothered by the fact that there was more depression correlated with more sniffus, because again, it seems like the measure itself is a little bit flawed. But ultimately, we wanted to really get to the bottom of the question. If you're a family member, or if I were going to a nursing home for subacute rehab and I had the option to choose between a sniffist and a non-sniffist, who would provide better care or who would result in better outcomes? So that's the main focus of my talk. I want to measure the effect of, we tried to measure the effect of physician and advanced practitioner specialization on post-acute care outcomes. And we wanted to also measure the cost associated with being treated by a sniffist versus a non-sniffist. Based on this prior work that we've done, we hypothesized that sniffist actually will result in better care at lower costs, or better outcomes at lower costs. Very briefly about how we did this. We analyzed discharges from acute care hospitals to skilled nursing facilities this is short stay, for Medicare fee-for-service beneficiaries over 66 years of age, physicians and advanced practitioners with at least 90% of claims for nursing home care were considered specialists, and we did some sensitivity analyses I'm going to show you in a minute that looked at different thresholds of specialization. Patients were assigned to the attending clinician based on, during their SNF stay, the plurality of claims that were submitted. And then that physician was identified as a sniffist or a non-sniffist based on their entire universe of claims. And those were the three outcomes I'm going to talk about in a second, a little more. So to do this, we use MedPAR, which is Part A claims for SNFs and hospital stays. Minimum data set is a resident assessment data set. It has a lot of rich clinical information, treatment information as well as some social factors that is commonly used to study the nursing home population. These assessments have to be done 5, 14, and 30 days after admission for a short stay, and then quarterly, or I think 60 days and then quarterly. So there's a lot of data there, and we use the admission assessment usually. And then MD-PASS is a data set that isn't, I'm not sure how commonly it's used. It's a physician level data set that provides the aggregate of the number of beneficiaries they saw in a year and also the number of services provided. So it's sort of the denominator that we used for each physician to determine the proportion of claims that they submitted from the nursing home. We tried to get Part B data for all the physicians who saw these patients, and it was something because Medicare goes by beneficiary, so it was 50 million beneficiaries were touched by the physicians we're talking about. I guess now I'm not surprised about that, but that was interesting one. I heard that the first time. So the study went from January 2012 to December 2014, and we included 2 million hospital discharges from 14,000 nursing homes. There are about 16 to 17,000 nursing homes, depending on how you count Medicare certified versus Medicaid certified. And we had about 50,000 NPIs in the sample. So let me tell you a little bit more about the outcomes. We wanted to focus on like a global measure of good care, and we kind of just went with well accepted things that Medicare and other health systems use. So we used the Medicare 30-day rehospitalization specification, which is an unplanned readmission to a hospital within 30 days of SNF entry. Successful discharge to community, which is defined as discharge to community within 100 days of admission to SNF, and the patient remained alive and was not readmitted to a hospital or SNF or another facility for at least 30 days. And we also estimated payments for 60 days. We actually started from the date of admission to the hospital because we felt that that's how payers really look at the episode of care between a hospital and followed by a SNF discharge. We also wanted to look at hospital payments as a way to compare the populations, so the 60-day payments, they were also adjusted. So if somebody spent more time in a SNF than 60 days, we adjusted the total payment for the number of days that was still in that episode. So the payments included facility and professional claims from Part A and B, which includes hospital, SNF, physician, and other provider payments. Unfortunately, we didn't have outpatient claims. Those are ED claims. We didn't have hospice claims, but hospice patients were excluded from this. And we didn't have a couple Part D medication costs were not included, although most of them are billed under Part A for the facilities. Our key variable of interest, again, is whether the nursing home attending clinician who was taking care of that patient specialized in nursing home practice. And we modeled, the specification included a lot of patient characteristics, demographics, race. We used Alex Hauser comorbidity variables because we were looking at readmissions. Medicare actually uses Charleston. We used Charleston just to check, and it didn't make a difference. And then there's a long list of variables that I can provide later, or is in the paper. I think it's in the appendix, of clinical variables from MDS and a few variables from claims that we used to try to risk adjust. We used nursing home fixed effects. So in effect, we were comparing patients in the same nursing homes that were being cared for by a SNFist to patients in the same nursing home that were caring under the care of a non-SNFist. We also tested random effects models and tried to estimate like a hierarchical random effect model, but we had 50,000 physicians. So that didn't work, but a simple random effects model was also tested. So this is our patient characteristics. Pretty much what you see for a patient population that is in subacute care in a SNF. Don't have much to mention here. I wanted to mention a little bit about the clinicians that we saw, because I think it's really important, and it's not, I think there's a lot more to be done in this area. But so there are major differences between SNFists and non-SNFists. This is at the stay level, because all of our analyses were at the stay level, but we're working on a paper to quantify this at the physician level, which obviously makes more sense. But not surprisingly, a large proportion of SNFists were nurse practitioners. That's something that we saw in prior slides. A lot of them were physiatrists who are PM&R physicians that I actually don't interact very closely with. So I had to look up whether this even makes any sense, and apparently a lot of PM&R physicians actually are primary care physicians in skilled nursing facilities. Obviously they are also for sure taking care of acute rehab patients, but I didn't know that they worked in SNFs. And then the distribution of specialties is very different, as you can see, for non-SNFists. And then we wanted to quantify the number of clinicians that were seeing these patients. So for SNFist stays, there were more clinicians actually seeing the patient, and they were providing more. The number of visits was higher, which kind of maybe is what we would expect. They have more time to spend with the patients, or what we would want if we had a SNFist. The number of SNFs with any of that physician's patients, basically how many SNFs does a SNFist versus a non-SNFist go to, and this also somewhat makes sense. So people who don't specialize in nursing home care actually go to slightly more nursing homes, but have fewer patients in each. And the last measure, the proportion of all SNF visits made to that patient's SNF, is higher for a SNFist, which I think also kind of makes sense on face value. So this is the big finding. So these are adjusted 30-day rehospitalizations. For non-SNFists, they were about 1.5% higher. So this is like an absolute difference in the rate of hospitalization. Successful discharge to community was not as impressive. Still, SNFists were doing slightly better job, but only 0.8% absolute difference, and the baseline rate was obviously much higher. And then the interesting finding that we had some trouble explaining or wrapping our heads around was the payments. So you would expect that lower rehospitalization rates would produce some sort of savings on this for the SNFists. I apologize, I couldn't put all the numbers in there. But again, SNFists are yellow bars and non-SNFists are blue bars, and the number indicates a difference SNFist minus non-SNFist. So SNFists actually had higher costs. They had higher costs for overall, slightly higher costs for the hospital stay, much higher cost for the SNF stay, and then going along with the findings of better discharge to community and lower rehospitalization, they had there were cost savings associated with those two rehospitalizations and readmissions to SNF. Part B costs, which included the professional claims and visits, were slightly higher, as we would expect. We were trying to understand why were the costs so much higher for SNFists for that SNF stay. So what we did was we added to the adjusted model rugs, and it looked like the differences were attenuated a little bit. And then we looked closely at the rugs that were used for stays under SNFist care, and those were systematically higher rugs. So these patients were getting higher intensity rehab care, or they were being charged for higher intensity. rehab care. And then the other interesting thing that we tested, we used different thresholds, well, I'll just tell you, this is how we did it. There are other ways of doing it, but it's kind of interesting that, so the darker bars are 90% of your claims are from the nursing home, and the very light bars are only 30% of your claims are from a nursing home. We kind of tried to address the question of, is there too much specialization? Is that potentially bad? What's the sweet spot? And you see for readmissions, it sort of starts dropping off at 50%. But for successful discharge to community, interestingly, the highest difference, most benefit that we were getting for SNFists was at the 80% threshold. So there's more work to be done in this area, and I think it might speak also to the mechanism of how these physicians or advanced practitioners, physicians are maybe getting these outcomes. And then one last thing I wanted to mention that also requires further digging into was that we stratified our findings into states where the primary clinician was a physician versus states where a primary clinician was an advanced practitioner. And we actually saw that most of our findings were concentrated among the states where the advanced practitioner, the clinician was a physician and not an advanced practitioner. So there are numerous limitations to this paper. We try to account for differences across SNFs by including SNF fixed effects, but we couldn't really adjust for patient selection. Conceptually, we think that if there is a SNFist in a SNF, perhaps it would be perhaps unusual, or we wouldn't expect them to select out healthier patients for themselves, because that's just not why they would be there. But that's something else that we need to work on in future studies. There might be other unobserved clinical, social, or time-varying hospital factors that we couldn't control for. Again, this is generalizable only to nursing homes that have both SNFists and non-SNFists. And this SNFist movement, if it is a movement, is still so early in the process that a very small proportion of nursing homes have both types of clinicians. It's unclear how, most importantly, I guess, it's unclear how the specialists, achieve, what is the mechanism for this association that we observed. And is it really related to the specialists, their knowledge, the time they spend? Is it somehow related to other staff that is working with them versus other people? And lastly, there were some data sets that we didn't have access to, like emergency room visits, observation stays. We also didn't include any clinic visits outside of the nursing home. So in summary, I think I'm gonna leave you with this, that it looks like there's a change in the makeup of prescribing clinicians who treat this population. 1 in 5 now are specialists, but there's a lot of variability. Specialization, it looks like, might be associated with better outcomes in mixed staff facilities, but at higher cost. And in part, those costs are due to more intensive rehab services, which may be a good thing, but also probably requires more studying. And then lastly, based on these kind of dose effect sub-analyses, we would in the future probably use a lower threshold for specialization of about 70% is probably where the most the widest difference between specializing clinicians and non-specializing clinicians was found, at least in our data. So I would say that based on our data, which is really early, Health systems aiming to improve post-acute care outcomes might consider strategies that shift their patients toward a specialist, a SNFist, especially given all the efforts in reducing 30-day readmissions. I was really impressed by the effect size in that measure. It also, one of the concerns of having a specialist is that they might want to keep that patient for a long time, leading to institutionalization of these patients, and that's not what we saw based on the successful discharge to community measure. But there is a lot of heterogeneity across clinician specialization thresholds, and all that would be included in the next steps for us. These are the next steps that I'm thinking of. I'm sure there are many, and I know we're kind of running out of time. I wanted to get your thoughts on this. And lastly, I just wanted to provide you with some updated slides with 2016 data. 2017 data I think is coming up in a month. But so since 2012, there was like a 54% change in the number of specialists per occupied beds. And in case, just as a sidebar, we did check, there wasn't a marked, change in the number of occupied beds, so it's really moving on the numerator side. I wanted to thank my mentors and other, the data sources and the Leonard Davis Institute of Health Economics for supporting this work and for having this exchange program. And obviously I want to thank IHPI for having me here.
Thank you. Hi, Kara. This is Julie Bynum. Thank you for this presentation. This is near and dear to my heart, as you know, as we talked about this earlier today. And one thing I really like about it is that I think a lot of people in the medical community forget that in nursing homes and skilled nursing facilities, physicians and clinical acute side people still have a very important role. And often it's a bit out of sight, out of mind for a lot of us. You're bringing attention to it. A couple comments and just a couple more thoughts about the future. First of all, I want to applaud you for your use of the public use files in a creative fashion. I have a junior faculty member here who were really trying to maximize the use of free data, and there's some really good stuff out there, so that's great. And then on your last slide about the rise, the SNFs, the timeline correlates with ACO expansion. I would love to see that across areas with high ACO penetration versus lower. Our work, John Wachang and I, with Carrie Kala, we're really actually showing, when you look at specific rehab populations, less benefit of the ACO movement on post-acute use, although studies that have taken generalized populations have shown reduced costs. We're not seeing it in groups who really use a lot of post-acute. So there's something interesting going on in that environment. And then just to go way back to one of your early slides, I'm really curious about the no visits work. And there's a couple reasons. First of all, from a regulatory standpoint, it doesn't make sense. Ought not to happen. So the question is really, are you able to capture, I'm sorry, this is a really weedy technical question, but there are types of providers, particularly in rural areas, whose claims don't show up in our normal carrier file. So I'm wondering if you're able to pick those up and being a little cautious about making a comment that in rural communities people aren't getting good care, they're not getting good visits, or are we actually missing the data? The examples would be FQHCs, rural health centers, and actually critical access hospitals, which could have swing beds and all these other kinds of things. So I wonder if you could just, in addition to taking the compliments and thoughts for the future, speak to a little bit to that rural funding.
Yeah, so when we saw those results, the first thing I did was I went to Rachel and I said, this doesn't make sense. What's wrong with my data? Right? And then we dug deeper into this. We talked to ResDAC, and that didn't go anywhere. But here's what I know. So we did like a pretty thorough thing where we looked at whether they had any Part B claims. And they do. We also looked at how long they were in the nursing home. We excluded people, or we did sensitivity analyses that I didn't have time to get into here, where we excluded anyone who was in a nursing home in the prior year to kind of weed out people who the physician might know. We also included clinic visits. So we included Part B claims. And kind of to just step back again, in terms of regulations, federal regulations require a physician visit within 30 days, but they also require that a physician is involved in the care plan, and that plan should be in place in about 7 days. And then I worked in a nursing home, and there were certainly patients who were admitted and sent back to the hospital before anyone got their hands on them, which might be perfectly appropriate. And then there were patients who were admitted on a Friday but really didn't get, so they might have been seen, like people waved to them from the door, or just looked and made sure that they were okay, but didn't actually put in the full Medicare visit that requires a physical exam and like a full thoughtful assessment. So that's, I think your point is very valid. There might be some visits or some care that physicians are not billing for because they're not meeting all the Medicare requirements for billing, or they're billing for it later, like they're providing the services that are needed, but they're making like the full assessment later when they have time.
Those visits I mentioned would be in the outpatient hospital file. They wouldn't be in the carrier file. So
Right.
in that file, you won't see them.
Right. The only thing that makes me think that, like, it can't all be, none of those explanations, like, each explanation can explain some of this, but then there's like a counter argument. So if these people are really getting visits, then why are they having terrible outcomes? If they're all getting sent back to the emergency room, well, first of all, why didn't the physician see them first, but maybe they weren't there, but then why are they they spend enough time in the nursing home, it looks like, to be seen before getting sent back on average. So I agree, I guess, but I think it requires more digging, and hopefully we'll be able to, what I'm trying to figure out now is how to tease out and see if we can actually match the population somehow, or use methods to compare outcomes by teasing out like this indigeneity issue.
So we should probably stop so Kira can get to her car to the airport. Maybe Dr. McMahon can walk her out to wait for the car. He has a burning question, but please join me.